Hi, everyone. We're going to get started in just a second. My name is Lacey Cook. I'm a project coordinator with the National Center for Disaster Medicine and Public Health. I just wanted you to take note over here to a little bit of instructions. If you experience any technical problems, you can send me a direct message with the chat feature. And if you have any questions or for Dr. Keim, you could just put them in the question and answer box that's right next to the slides. I have with me here our center director, Dr. Tom Kirsch. He's going to give you a little bit of an overview about the center and introduce Dr. Keim. Tom?
Greetings, everyone. Welcome to the conference. This is an exciting topic and a great speaker, and we're looking forward to hearing what Mark has to say. Just as a background, the National Center for Disaster Medicine and Public Health has been around for a number of years. We've had a webinar series going on, and this is our latest iteration. The center recently has taken efforts to redirect its activities with a greater focus on science and education, and we're moving out in that direction. Dr. Keim is currently acting as our senior science advisor and taking the lead on some overview projects we're conducting on the current state of disaster science and the current state of disaster education in our nation. He is an ex-CDC person for a number of years, is a widely recognized both globally and domestically in the disaster world, and has been involved in events from as far back as having his home blown away by a tornado in medical school, to the Atlanta bombings, to detailed preparedness activities, particularly related to climate change in the South Pacific. And I'm really looking forward to his talk. Mark, it's up to you.
Mark, you can go ahead.
Thanks so much, Tom. Can everyone hear me okay? Fantastic. Okay, well, we'll go ahead and get started then. So thank you so much, everyone, for taking the time out of your day to join us, and I'm going to make this definitely worth your while. We're going to talk about some exciting topics, and hopefully we'll be able to learn some things together. So first slide, I just want to share with you a couple of different things. The topic itself today is From Reaction to Prevention, and it's a call to action for us to start becoming involved with preventing disaster-related injuries, and I'll talk more in detail about that. So first off, I want to start off with a little story here. I tell you a story about disaster risk reduction, and I can't tell this story, of course, without dating myself. Some of you out in the crowd actually may recognize the Weekly Reader. This was a children's newsletter that was available when I was growing up, actually, in the Midwest, and through many areas. It was actually published in the Midwest, but available throughout the United States. And basically, it was a newsletter where children could read these weekly newsletters at their own level of reading for that class level. And so children would order these weekly readers, and at the back, there was a place where we could actually buy books. And so that was always a wonderful opportunity to buy the books, and my mom was always a tough sell when it came to buying toys, but books, she was always a soft touch. And so here I was, 7 years old, and reading the Weekly Reader, and I bought a book on tornadoes. And in that book, I learned how tornadoes form. I learned how they act, how they behave. I learned how they what direction they move, predominantly from west to east. I learned that they don't turn back on themselves. They don't turn due north or due south. I learned that they move predominantly in the region, in the speeds of 30 to 40, 50 miles per hour, not much faster than that, of course, and then the sizes and so on. So here was this boy, 7 years old, fascinated by this book of tornadoes. And I want to just now take you 15 years later here. This is the home I was living in Marion, Illinois, when I was 22 years old. And so I'm going to pre-med at that time and studying to be a doctor in Southern Illinois. And then came Memorial Day weekend of 1982, just a few months later. It was unseasonably warm that weekend, and actually I was studying, of course, in pre-med. My wife was cleaning the house, ironically enough, and we heard an alarm go off. We heard the sirens go off. And in our community, we had a volunteer fire department that was actually called to the fire by siren. So at first we thought it was the siren going off for the volunteer fire department. So here's a good lesson about warning and early warnings. And so actually it kept going off, and my wife actually mentioned it to me, and I walked outside, and when I walked outside, I looked across the horizon, and I saw a picture similar to this one in the middle bottom that you see on this particular slide, where I saw a tornado off in the distance, and for the first time in my life, I was actually seeing a tornado ever since reading that book when I was a young man, and a young boy. And so I ran into the house. I pulled my kitchen table into the center of the house, as I learned to get in the center of the house in the book, and my wife got underneath the table. I then ran back outside to see any of my neighbors were home, because I knew they had a basement. And of course, I went over to my next door neighbor's house, banged on the door, no one there. It was a beautiful Memorial Day. They were out enjoying the day, of course. And it was that point in time I actually thought about kicking in the door, but held back from that, actually, because everyone thinks that we're that it's not going to happen to us, of course, right? And so as I was crossing back across the road to my own home, I looked across, and that's when I saw the tornado hitting this brick schoolhouse in the left upper corner of this slide. And I watched as the brick left that schoolhouse, went up into the tornado, turning it red, and then rained down on both sides of it for blocks and blocks wide. And it was then that I realized that actually this single story wooden structure that I was living in wasn't going to work. It wasn't going to be safe. And so I ran back in the house, and I grabbed my wife out from underneath the kitchen table, who was not too pleased to leave what she had considered to be adequate protection at the time. And then we ran back outside, and I got in the car, actually, and I went down this path that you see here, this evacuation path, went due east and then turned due north and went past the tornado. The tornado path, as you can see in this particular drawing, is here. The tornado path went this way, and I went that way. And I knew, actually, by seeing the tornado, that when I saw the tornado, it was about right over here, hitting that schoolhouse. And when I saw it, I knew that it was moving slow enough that I could actually get out of its way, although I wouldn't always recommend getting in cars. But in this particular example, that second effort, that second idea really made a difference in saving my life. And so actually, there's the before, and there's the after picture of my home after the tornado hit. So you can see it would have been a bad situation if I would have stayed in the home. And actually, my home, this home, used to be over here. This is actually my driveway, where the home, roof taken off. These are the interior walls. The only thing left, all exterior walls taken off and destroyed. And then the entire home moved over onto my driveway. This is actually the beginning of my neighbor's home as well. So you can see very severe tornado. Category 4 and 5 is what it was estimated for, and much too high of winds for me to be in a single story wooden structure. And it was that second effort. So what saved my life? Well, amazingly enough, what saved my life was a weekly reader, a children's book when I was 7 years old. And one of the things I learned later on, actually, this is a publication that was published by the CDC, ironically enough, that showed that that particular tornado, all deaths occurred in the impact phase. So what does that mean when we talk about the impact phase in disasters? So the impact phase is actually when the disaster is occurring, when the wind is blowing, when the ground is shaking, when those things are actually occurring. That's the impact phase. And so most people die right then. And I think that's an important thing to consider when we're talking about these disasters. And I'll talk more about that in detail in this presentation. So then afterwards, the good news is I was out of school for 5 years, working and trying to get to afford to go back to school after the tornado. And I was able to get back into school, became an emergency physician, and then worked in a career for CDC, going all over the world doing disaster work. And I like to think that that little book, that little $1, $2 book that saved my life and saved my wife's life, perhaps in the future over time, saved quite a few other people's lives indirectly as well. And so one of the things that I learned during this process was this idea of resilience, really has three components. One of them is you have to survive to begin with. I say resilience is for survivors. And you must live through that initial onslaught, live through that initial hour before we can actually consider you to be resilient and move towards rehabilitation and recovery. So that's an important point when we recognize that many of these disaster deaths actually occur within the first hour, as I've mentioned, occurring during impact. So let's take a look at that in more detail. When do most disaster deaths occur? Well, looking at this slide, for example, the line itself, the red line, is impact phase. And we talk about pre-impact and post-impact phases of disasters. And so pre-impact, in the old school model, we would talk about prevention, mitigation, and preparedness. All of those we do before the impact occurs. And then afterwards, post-impact, we have response and recovery. But when do most deaths occur? They actually occur right on that red line. They occur during impact itself, before response occurs. Before response occurs. And so that's very important when we consider these natural history of disaster-related injuries. Now, some of you may not be physicians or nurses, but you may have stayed at a Holiday Inn last night and be able to understand the medical aspects of this. For those of you that don't, it's relatively simple. I'll go through this with you as well. But basically what we're talking about is the natural history of disaster-related injuries. They usually progress in a regular, predictable way. There's a stage of susceptibility where this is before we are injured, before the exposure occurs, where we may be susceptible. We may be susceptible to injury from sun, from heat, from trauma, from blunt trauma, and so on. And then there's an exposure. The disaster event occurs, and then there's a stage of subclinical disease. For example, if this exposure is from a bacteria, it may take a few days before we have onset of symptoms. However, if this exposure is from glass flying across the room, then our pathological changes, meaning our injuries or our changes of disease, would occur very quickly. And so therefore, the time between exposure and the onset of symptoms is usually, in disasters, most injuries in general, only seconds to minutes before we actually have this onset of disease. And then once the onset of symptoms, most of the time in injuries, we have what's called a golden hour. A golden hour, that means from the onset of these symptoms or the onset of the exposure until the surgical intervention, until you're actually in surgery, not just in the ambulance, not just in the ER, but in surgery. That golden hour really makes the difference whether we survive or not. Most disaster deaths actually occur during this period of time between the seconds to minutes and during that golden hour. So we have to think in terms of disaster response coming after that golden hour. Then how effective are we really in approaching these kinds of injuries when we're actually arriving many times too late? So let's look at that a little bit closer. Now, this is the epidemiology for trauma deaths in general, and not just trauma deaths from disasters, but all trauma deaths tend to occur in the same trimodal distribution. So what does that mean? It means that immediately 50% of all trauma deaths occur nearly immediately, within seconds to minutes, as we pointed out. And then 30% occur within hours, most of them 4 hours. Actually, most of the 80% occur within the first hour of injury, after injury. And then the other 20% occur over the next few hours, days to weeks. So let's put this in terms of disaster response. For example, that tornado, had I been injured in that tornado in 1982, I would have had an 80% chance of dying within the first hour if I had a serious enough injury, and then a 20% chance of dying after someone had found me and rescued me, perhaps. So we can see here a lot of these injuries are occurring before anyone gets to them. And we've even seen this, actually, this paradigm, this model, it has been extrapolated for those of you that are joined us from the armed services. You know the golden hour after combat injury, and this has actually changed according to our resuscitative capacity in the U.S. military, where pre-2015 we talked about location-based triage and combat injury care, the echelons of care. And now we're talking about physiology-based, where we're talking about advanced resuscitative capability within the first 60 minutes. Once again, recognizing that most people, their physiology pushes them towards towards mortality, towards losing their life in the first 60 minutes. So we have to actually change the way that we treat casualty care, and that's what's predominantly happened in the U.S. military doctrine. But the difficulty is that we haven't done so yet for disasters in particular. And one of the books that I recently wrote, this is an ebook that's available for free download at my website, DisasterDoc.org. In that particular ebook, I point out these 10 reasons why disaster rescue is often too little and too late. And reason number 7, as I've alluded to earlier, most disaster deaths occur during disaster impact, when even local rescue is impossible to deploy. So, for example, when those hurricane winds are blowing at 100 miles per hour, you can't put an ambulance on the street that would actually reach those people in time. The ambulance would be blown over. Rescue teams can be injured during earthquakes, during tsunamis, and so on. So, therefore, that golden hour that we're talking about, that's so critical when we're talking about routine, everyday emergency medical care, and we almost are excluded from that hour when we talk about disasters and the kinds of hazards that are between us and reaching the patient. And finally, when we do send in teams, whether they're local teams or state teams or federal teams, you can see that the time grows longer and longer depending upon how long that team has to travel and what assets that they're bringing in. So once again, we're looking at a model that for 80% of the people actually die before rescue even arrives. And even if we were to arrive within that, after that first hour, let's say, for example, that we arrive, within hours of the event itself, then you can see here in this particular slide that delay after even after rescue, a delay of resources, delay of allocations, and so on, is actually more commonplace than not. Zika, tsunami, earthquake, Katrina, Hurricane Sandy, Ebola response, Indonesia, tsunami, and so on, over and over and over again, we're experiencing not only delays in funding, delays in assets, but also delays in organizational efforts that can reach out and touch people and help them make a difference in a big period of time. Or in a short period of time, I should say, excuse me. So we also can expect these elements to actually worsen over time as global climate change is predicted to increase the probability of these extreme weather events. And so we can expect extreme weather events to occur predominantly in two main categories: high precipitation disasters like storms, floods, and landslides, as well as low precipitation disasters, heat, drought, and wildfire. And so with these disasters are going to become more frequent over a period of time over the next 100 years as predicted, then we should expect to have more of these extreme weather events. Therefore, we should start thinking in terms of reducing our risk as opposed to an ineffective and costly response-only method. I'm not saying we should avoid response. Of course not. I'm an emergency physician. I recognize the value of response and emergency care. But I also recognize the value of controlling your cholesterol, controlling blood pressure, controlling all those other things that are risk factors for your heart attack before you come into the emergency department. So this is a good example of how we should be thinking in terms of both cure as well as prevention when we're talking about disaster-related injuries, and especially disaster-related injuries. And so, as I mentioned before, we can expect these disasters to increase over time, and we're already seeing a remarkable increase in weather-related disasters or hydrometeorological disasters, as you can see in this particular slide from the United Nations. Worldwide, these hydrometeorological or extreme weather event disasters are increasing, and remarkably so since the mid-1990s. And once again, if we can expect more increases, we should be thinking about more effective means for actually addressing those injuries and illnesses that can occur. And so over a period of time, what we've actually seen is an evolution of approaches from whenever I first started at CDC in the old days. Oh, in my old, the OG days, right? The original CDC days, we were doing response after response. And I can remember talking to one of my bosses about preparedness in the early 90s. And he thought that was just so far-fetched because of the expense and the movement. But yet here we are, millions and millions, hundreds of millions of dollars of preparedness and money's being spent. And now we're moving to the idea of risk management. So in the old days, we would respond to floods. Then we started preparing for floods. In this example, we actually now are trying to prevent the flood from occurring. And if you cannot prevent the flood, then prevent the people from being injured in the flood. If you're not in the water, it's pretty hard to drown. And so that's one of the main focuses: location, 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 when we're talking about these evolution of approaches. So this approach is actually called disaster risk reduction. And many of you have already heard some of these phrases coming from overseas. As a matter of fact, it's a very popular paradigm overseas, and is now really spreading across the world as the newest movement for disaster management, disaster risk management. So risk is the probability that an event will occur. And in epidemiology, or what we're interested in public health, this study of these health risk determinants, it's used to express the probability that a particular outcome, like a bad outcome, like an adverse health event, will occur following a particular exposure. So in our case of disasters, especially these extreme weather events, we're talking about exposure to these extreme weather events, to these extremes and these hazards, and then an outcome of injury or illness. And most of the times these are injuries. And so that's the risk of disease for us. And what we want to think about is this in terms of the causes rather than the effects. And so if we're going to reduce the risk, in other words, if we're planning to prevent the disease from ever occurring, we need to be thinking about reducing the risk factors as opposed to accepting the risk and reducing its effects. So does that make sense? So we should be looking at the primary causes of the hazard occurring itself, people being exposed to the hazard, and then also their own vulnerability. And we'll talk in detail about those, as compared to what we have predominantly done traditionally, where we've looked at mortality, that's the deaths, morbidity, which are the injuries, the displacement of the people, and of course their loss of livelihood. So in the past, we've dealt with the effects in sort of a curative rescue approach. And in the future, and now around the world, people are now starting to look at these causes so that we can actually prevent them, either prevent one or the other, or perhaps all three. But we have to find a way in order to act before this event occurs, to act before the disaster impact itself. And why is that? Well, one of the things looking back again, once again, looking at these causes of death, in particular in the timing, when we look at these extreme weather events in the United States and what the causes of death are, we can see that tornadoes, for example, the main causes of death are head, chest, and spine injuries. In cyclones, like hurricanes, for example, those are drowning in many cases, or from recovery acts there fall off the roof, electrocutions, cuts, and burns. Also from floods, drowning, and from landslides, asphyxiation, or in other words, suffocation that may happen. So you can see in these red, these extreme weather events that are noted in red and the causes of death, these are something that occur very, very quickly. Head injury, chest injury, spine injury predominantly die very, very quickly. Drowning is a very quick event as well. And also asphyxiation or suffocation, only just a few minutes for all of these. So if we're looking at increasing extreme weather events, especially when we're talking about storms, flood, and landslides here in the United States, we can expect many of these causes of death, many of these deaths to actually occur before we could be expected to arrive as even ambulance, let alone as state or federal responders. So I want to go into a little bit more detail with you about what we're talking about when we talk about these causes of disaster injury as opposed to the effects of disaster-related hazards. So first off, what is a hazard? Well, this is a long definition. It's obviously United Nations. I always love the United Nations definitions of never less than a paragraph. But it does have a part that we are concerned about, a component in particular, that this condition may cause a loss of life, injury, or other health impacts. So that's what we're worried about, hazards. Hazards are dangerous stuff, and they can cause us to become injured. So we want to prevent hazards whenever we can. Now, we may not be able to prevent this volcano from erupting, but we certainly can prevent the next piece, which is exposure to that particular hazard. So we can't prevent the earthquake, we can't prevent the storm, but we can protect people's lives from being exposed to these. And so what are the types of hazards we're talking about? It can be floods and typhoons, or it can be man-made like radiation, or earthquakes as natural disasters, or even biological disasters as well. All of these are considered to be hazards. They're the things that can cause us harm. And then these hazards are then, people are then exposed to these hazards. So what is an exposure? It's any condition that provides an opportunity for a hazard to come in contact with the body. So if we're exposed to a volcano, we have to be near it. If we're exposed to the flood waters, we have to be in it. So once again, it's a matter of location, location, location. And we do different things to prevent our exposure. For example, in this particular slide, the unfortunate lady the gentleman could have covered his mouth, or she could have personal protective equipment on. So there are ways that we routinely limit exposure in many aspects of public health and medicine as well, with personal protective equipment and so on. But we also do with public health with evacuation. And I think that's an important role for not only public health, but medicine and people who are promoting public health in particular. That's an important role for them to play, is becoming involved in that evacuation. And I know that FEMA also, FEMA leads that effort as the lead federal agency, obviously for evacuation, but of course public health and Red Cross have a very important role to play underneath that federal response. And so finally, in order for us to have a disaster related injury, we have to have the hazard, like the tornado, the exposure, be close enough to the tornado, and then be susceptible to that hazard. So in other words, to be vulnerable to that hazard, susceptible to the damaging effects of that hazard. So for example, if I've been immunized against measles virus is the hazard, but yet I'm no longer vulnerable because I've been immunized, so I'm no longer susceptible. So my possibility of injury goes down to very near zero in that case. So that's our idea, is to limit or lower either the hazard probability or the exposure probability or the vulnerability itself down to a point where it makes the equation zero. In other words, that with no vulnerability, there's no risk of disaster-related injury. If there's no exposure, there's no risk of disaster-related injury. If there's no hazard, there's no risk of disaster-related injury. So that should be our focus when we're talking about prevention, and we should be adding this into the curative aspects of that we're already doing such a great job with in emergency preparedness and response. So how do we reduce exposures? Well, we're already doing that in many, many areas with floodplain management, where we develop dams and levees and weirs that prevent people from actually being in the floodwater. And if we can't do that, if the flood actually does reach these population centers, then we, of course, have the responsibility to evacuate the population and, of course, provide mass care, mass sheltering and food and so on for these people. And then also as well, land use planning and regulation actually reduce exposures in the long term. Building codes as well make our buildings less likely to crumble in an earthquake or a tornado and so on. So therefore, they reduce our exposure to these dangerous hazards. As we often say in disasters related to building failure, whether it's a tornado or earthquake, many times it's not the disaster that kills people, it's the building that kills people. So building codes and better land use and so on really can make a difference in reducing those exposures. And then finally, personal protective equipment, sanitation, hygiene, we use those routinely on a daily basis almost to prevent ourselves from catching infectious diseases. So we wear gowns, gloves, and masks in the ER. in hospital settings and clinical settings and so on. We also, as our mother taught us so well, to wash our hands before we eat and so on. Those are sanitation and hygiene issues that also reduce our exposures to these dangerous hazards on a daily basis. And so by adding that same phenomenon, by adding that same process to our work in reducing exposures for disaster-related injuries, it also has the same effect. And so the next thing I'd like to show you is just how big of a difference those tornado deaths have been, the change in those tornado deaths over the past 30 years. So I started off my presentation today telling you about my particular disaster experience with a tornado. But I wanted to share with you this study by Brooks et al. Talking about U.S. tornado deaths per million people. And you can see here it's a pretty remarkable drop over 3 decades, especially over actually a long period of time, but in particular, most importantly, over the past 3 decades, where we've seen almost a 10-fold drop in tornado deaths. And this hasn't been due to increasing capabilities at the hospital. It's not due to the cooperative agreements that we've put together at Public Health or WHO or CDC or HHS or any other place around the world. What we can really say is this is actually due to less exposure. It's due to the improved forecasting and early warning that comes with Doppler radar. It's due to the improved communication through our phones and our televisions earlier on and now our phones, and also changes in construction where people are dying less frequently in built construction. But I must point out actually that we are having an increase in deaths at the same time due to modular or manufactured homes. So this isn't due to the health sector, yet the health sector is spending hundreds of millions of dollars a year in disaster response in order to try to lower death rates. But yet this death rate is decreasing outside of that. And so I point this out to you to say, you know, what could we be doing if all of us combined together, and not only the National Oceanic and Atmospheric Administration and the National Weather Service and FEMA, for example, involved in giving these people these warnings for dropping these death rates, but also public health communication, risk communication, and so on. There's a lot to still for us to do in the preventive aspect of this, and you can see that these accomplishments are actually quite remarkable. I just challenge for any of you to name a handful of diseases where you've had this kind of a decrease in death rate over the past several decades, where you can say that it's actually decreased tenfold. Not many opportunities in public health for those kinds of successes, but here we have one right in front of us that we need to take to heart. So as I mentioned before, reducing vulnerability is one part of this process. Another is, reducing exposure is one part of this process, and another is reducing the vulnerability. So how do we reduce vulnerability? Well, one is we do what we do, right? In medicine and public health, we reduce vulnerability by promoting health. Healthy people survive disasters better. When people have better access to healthcare, when people have better access to other ways to reduce their vulnerability of healthy lifestyles, when people have the means and the resources and aren't poor to address their health, they're healthier people, they are less vulnerable to disasters. Actually, poverty is the single most important risk factor for dying in a disaster worldwide. So that tells us a lot about the preventability of disasters as well. Also, community planning, immunization, education. There are many ways that we can actually lower our individual vulnerability for disasters themselves, and we're doing actually a pretty good job of this overall. Then this also matches into the National Prevention Strategy. The National Prevention Strategy, you can see the components here: healthy and safe community environments, the clinical and community preventive services that are involved in National Prevention Strategy, empowering people, and elimination of health disparities. All of these match in together well with a model that also reduces disaster-related vulnerability. So you can see we're not creating a paradigm that's completely separate from public health. What we're simply doing in disaster risk reduction is we're merely moving public health towards injury prevention and control. We can't cure all of the injuries. We can't prevent all of the deaths when they are rolling into the emergency department, when it's too late and they're rolling into the hospital or in the ambulance. We have to prevent these injuries up front to begin with. And that's the idea of the National Prevention Strategy for all adverse health events in the United States, and it matches also those with disasters as well. So what is this disaster risk reduction for health that I'm talking about? Well, it's preventing disaster-related adverse health impact before it happens. So it's basically injury prevention in many cases. If it involves infectious disease, of course, then it's disease prevention and control. And we deal with the root causes rather than the effects later on. So we want the root causes themselves. And why disaster reduction? Well, number one is I've just gone through with you, the majority of disaster deaths occur during the impact phase. That's when we have to intervene, or beforehand. And also, it's more effective in reducing mortality, as you've seen before. The other thing is actually quite remarkable. Is a recent study, actually it's now being repeated actually by FEMA. I just heard this at the Boulder meeting last week. That the FEMA study reports that disaster risk reduction saves, for every $1 saved in disaster risk reduction that you spend in disaster risk reduction, you save $4, in some cases up to $7 in response and recovery costs. So it's 4 to 7 times more cost effective. When we look at World Bank studies on a global level, we can see that actually disaster risk reduction for every $1 spent saves $20. So it's much more cost effective, it's much more humane, and much more appropriate for public health when we're talking about lowering mortality. If that's our goal, if our goal truly is to lower mortality as a result of disasters, we need to be thinking about getting to the left of the bang. So what do I mean by the left of the bang? I mean before the bang happens, before the bad thing, before the occurrence happens. Frank is asking me if we can get a copy of the slide deck, and absolutely, Frank, you can get a copy of the slide deck. We're going to make that available for everyone. We're also recording this particular presentation as well, so happy to share, Frank. Okay, and next slide. So basically what I'm asking you to do is join us. There's a lot of effort already going into disaster risk reduction. In particular, what I want to recognize is the United Nations International Strategy for Disaster Reduction actually started in the 90s. And the 90s were considered to be the decade for disaster reduction worldwide. And then another key event that happened was the 2015, first off the 2005 conference on disaster risk reduction that happened in Kyoto, and then after that as well, the disaster risk reduction conference, the second one that happened in Sendai in 2015. Very big seminal event in Sendai. So what happened there was all countries of the world, all countries of the UN, I believe it was 187 at the time, came together and agreed to reduce the disaster risk in their individual countries and in their individual nations one by one. And all of them agreed. This went out actually as a declaration around the world, and many of them, although non-binding, are taking tremendous efforts actually to reduce disasters in their communities and in their nations. Many of the countries that have recurrent chronic disasters, for example, are now reducing that risk. Vietnam, Nepal, other areas are actually leading the world in much of this disaster reduction, very, very remarkably so. But what we're seeing actually is America, in the United States in particular, we haven't followed that same route as aggressively. And I think part of the reason is we can afford not to. To some extent, at least in the short term, we can afford response and recovery, even though it is expensive and costly and wasteful. Whereas other nations just simply can't afford to even do the first set of responses and are already looking for the kind of options, the kind of alternatives that would lead to lower risk and lower costs, lower losses, in particular of life itself. And so this idea of the World Conference of Disaster Risk Reduction, the United Nations Office for Disaster Reduction. Those are focused on that international message. And then down below as well, World Health Organization, still very focused on disaster risk reduction. An office in Geneva now focusing strictly on disaster reduction itself and continuing to move forward. And of course, my own group as well, DisasterDoc, that's our focus. We recently actually very honored to win the Sasakawa Award Certificate of Merit at the Sendai presentation, the World Conference in 2015, for the work that we're doing on a global level in disaster reduction. I'm committed that I think disaster reduction is the wave of the future. It certainly is the next paradigm for all of the world. Many areas are already moving in this. It makes sense for all of us. It's cost effective, it's more humane, and it's a much more appropriate way to spend our money that's less wasteful. So I just encourage you to join us to follow these various organizations and to check them out. Last year on Disaster Risk Reduction Day in November, you can see on the World Health Organization website, they did a special event focusing on disaster reduction and in particular identifying reducing mortality as one of the 5 goals that actually came from the UN World Conference on Disaster Risk Reduction. So that's us, folks, reducing disaster mortality. No one can do it unless we all do it together. And so I just wanted to share those with you. Those are other opportunities. I mentioned, Frank, that you can find actually, Lacey just sent you the link for the NCDMPH site where you can find the link for this presentation. Also, you can find more information about many of the publications that we've already addressed about disaster risk reduction and other presentations that I've given on the same subject and others as well in disasters at the DisasterDoc archives at disasterdocacademy.com if you'd like. Those are all free of charge as well. And so finally, I just want to say thank you so much to everyone who have joined us this afternoon. I'm glad that we've had the opportunity to share this information with you. I'm also open for any future questions that you may have as well. You can contact me by email or also through this website as well. And Claudine asks, is this the same site for audio? Lacey, could you answer that for us, please? While we're waiting for that reply, is there anyone else? While we're waiting for that reply, is there anyone else that has questions as well? If you'd like to be able to join in, please feel free to pop a question on there, and I'd be happy to answer them. Also, I want to, while you're doing so, I want to give a shout out to some of my friends out here I see on the line, Brian Flynn, Andrew, as well as I saw Nisha on here. We have a few other friends here, Kelly, and quite a few of you have joined us. Tricia, thank you so much for joining us. So I think Lacey has answered the question. There'll be a full recording of this session posted to the NCDMPH site above. Also on my particular DisasterDoc Academy website, if you'd like to go there, you can get a download for the entire PowerPoint presentation. I'm always happy to share that with my friends as well. Please feel free to use it in whatever way you like. File the serial numbers off. As long as the information gets out there, then I'm a happy man. Thanks everyone, and I really appreciate it. Any other questions that we may have, or any other comments from anyone out there in the group? Have one comment here. Mark, are Medical Reserve Corps involved in your org? And actually, Mark, I've been working with the Medical Reserve Corps. It's amazing that you say that. Actually, I've been working with the Medical Reserve Corps since its inception, actually, back when I was at CDC. And we are actually working with the Medical Reserve Corps. I've presented at a couple of the regional meetings for the Medical Reserve Corps, and since starting with the business. Also, I developed a training program focusing on core competencies that we were able to share with a few of the groups as well. So yes, we have an ongoing relationship, but not something with the entire formal signed declaration or formal signed agreement with MRC, but we do support all the individual units as well as the national leadership. And I have another question here from Brian Flynn. So he says, great, Mark, can you speak to where you see psychological trauma fitting in? Absolutely, Brian. And actually, I think this is a key element, a key issue, and you know that how strongly I feel about this. You know, years ago, and I'm dating myself, of course, and Brian, I know I'm dating you as well, but you know, we would ignore these exposures. People would be exposed to traumatic events, and we would actually ignore the psychosocial trauma. I can remember those days very clearly when I first started in the disaster business, or perhaps even a disaster victim. And so now it's important, of course, we've come a long way from that, and recognizing that exposure event from trauma, and then there may also be a delay of onset of symptoms, and then a symptomatology or a set of symptoms that actually extend not just for a few days, not just until the person's back in their home, but can actually go on many years after what the rest of us would look at that community and say, well, they're already recovered. But actually, the psychosocial trauma of going through these events, as we know now, and we can appreciate with further studies as well, that it goes on and on and on. And so I think preventing the psychosocial trauma is also an aspect that's very important. For example, if I'm evacuated from an area, if I have a good evacuation, whether it be at risk for landslide, at risk for tsunami, at risk for storm surge and flooding, you know, I'm not there to watch that kind of carnage. I'm not there to experience that psychosocial insult. See those hazards, see the loss of life, and go through many of those traumatic experiences. So that by itself, I think, is a good example of how much of this goes together. When we're talking, we shouldn't consider psychosocial injuries or psychosocial illness to be any different than any of the other injuries and illnesses that we're treating, and we should be trying to prevent many ways that we're doing so with other issues related to violence and so on, but also as well, I think we need to address it when we're talking about our response capabilities or our prevention of those kinds of things, those kinds of events when we can and when they're predictable, for example, like in extreme weather events or predictable advance warning events like tsunamis or hurricanes and so on. Does that address your question, Brian? Thank you, Brian. And now Mary has a question or comment. CMS is working with agencies, hospitals, HHA, hospices, etc., in emergency preparedness. How do you see HHS agencies fitting into this model? Very good question, Mary. Thank you so much for that. Well, I think the importance of evacuation, of safe evacuation is not to be understated. You know, when we evacuate people, whether they're in hospitals, whether they're in hospices, we place them at risk. We increase their risk by moving them around. And so we have to take that seriously, that the evacuation process itself is actually dangerous and increases a patient's risk, and we shouldn't do so. We shouldn't take those kinds of steps lightly. So we should have careful plans. We should have careful processes that are tested and based upon evidence. And those plans, especially for these institutions and agencies, should not be in isolation. We should be working as a whole of community in order to evacuate hospitals, a whole of community to evacuate hospice, to evacuate nursing homes in a way that don't put on a burden of disease onto these people, whether it be injury, illness, or psychological or behavioral illness as well. So I think that's an important aspect of the CMS role in this emergency preparedness, is preparing to evacuate, not just merely turning on the generators and hoping for the best, but actually a model for mass evacuation. And that's not the easiest thing to do in the world. Of course, I know I'm speaking to many of you that have had this experience, but I've worked with many areas of the world as well where hospitals are evacuated repeatedly. In one particular country I know of that evacuated its only hospital twice in 6 months. And you can imagine the burden that put upon the entire hospital itself. And they were very, very lucky to not have more deaths when they do so. So once again, I think it's a very key issue. I think it's not only the role of the CMS preparedness aspect, but I think we should be talking about not just preparedness for the inevitable injuries, but prevention of injuries to begin with. And so thank you so much for that question, Mary. Anyone else have another question or comment regarding this topic? I know it's some of you it's a old hat. Other people this may be actually relatively new. So anything else you have to say, a comment or a question? See, we have a good span of people both from the feds as well as state organizations and private. That's nice. I'm looking through the lists here. Anything else I can draw down on? All right. Well, having heard none, I just want to say once again, thank you again so much for taking the time to join us this afternoon. If you have any further questions or comments or something that you'd actually like to send me, please feel free to do so. You see up there DisasterDoc.org. If you put Mark at in front of that, that's my email address, mark@DisasterDoc.org if you have just a personal or direct email question. Otherwise, please feel free to contact Lacey Cook. She's giving her email address there as well. And we're all looking forward to hearing from you and just love to hear your comments or questions. And also, please feel free to send me a little jab. Hey, Mark, you could be doing this better or that better. I'm always interested in being able to grow and do these things and communicate better with you. So once again, thanks for your time. I really appreciate it. And until next time, close for now. Bye-bye.